Welcome to the AOA Future in Orthopedic Surgery podcast series. This AOA podcast series will focus on the future in orthopedic surgery and the impact on leaders in our profession. These podcasts will focus on the vast spectrum of change that will occur as the future reveals itself. We will consider changes as they occur in the domains of culture, employment, technology, scope of practice, compensation, and other areas. My name is Doug Lundy, host for this podcast series. Joining us today is Dr. MaCalus Hogan. Dr. Hogan is the David Silver Professor and Chair of the UPMC Department of Orthopedic Surgery and Chief of the UPMC Orthopedic Surgery Service Line. He obtained his undergraduate degree in biochemistry from Xavier University in Louisiana, where he was also a Howard Hughes Institute scholar. He attended Howard University College of Medicine, where he completed his medical degree, and then moved on to the University of Virginia Health System to complete his training in orthopedic surgery with a research focus in musculoskeletal regenerative engineering as an NIH T32 fellow. Following residency, Dr. Hogan completed his foot and ankle fellowship at the Hospital for Special Surgery and then obtained his Master of Business Administration degree from the University of Pittsburgh Katz School of Business. Additionally, Dr. Hogan currently holds the position of the director at the Foot and Ankle Injury Research Group within the Department of Orthopedic Surgery. He serves on the board of directors of the American Orthopedic Foot and Ankle Society and the J. Robert Gladden Orthopedic Society. He also holds secondary appointments with the School of Engineering, Bioengineering, Clinical and Translational Science Institute and the Katz Graduate School of Business and International MBA program at the University of Pittsburgh. So Dr. Hogan, welcome to the podcast, sir.
No, thanks, Doug. Thanks for having me.
Man, it's great to have you on, my friend. And you're from one side of the state and I'm on the other side.
Absolutely. As they say, two ends of the Commonwealth, as they say.
That's right. All right, my friend, we're going to talk about, if you could, about the changes in large system hospital employment, and UPMC, I believe, is an outstanding example to describe what things are going there. But before we get there, my friend, you have had a distinguished course in leadership to get you where you are. What kind of advice can you give based on your course, your pedigree in leadership, of what others can gain from that?
Thanks for that question. When I started residency and I was headed to UVA, my mentor at the time, Dr. Richard Grant, who's retired now, said to me, keep your eyes open, ears open, and mouth shut. That's back when you could actually say that to someone or to a medical student and there not be some level of offense. And I was fortunate for the time along my journey, whether the mentor was my father or mentor people such as people like Richard Grant and also at UVA, I was fortunate to have great mentors who were willing to essentially invest in me and give me the opportunity to just be around them and be in the environment of not only excellent patient care, but leadership of their peers, of their practices, of other groups of individuals. What I would say, the first piece of advice is just that, have a willingness to be present and just aware so you can just take things in. And you can be active in an environment without saying a word and without getting in the way. And that has been one of the main approaches I've taken. One plug I'll also say is my dad, who's still with us, Freddie Hogan. He was an economic development business guy in the South, worked for the government. And he used to always say, when you go to your first meeting, it's very important that you don't say anything, just listen. When you're willing to do that, you learn about opportunities, you give yourself time to think. And I think that's just very important in leadership. And all of us are busy, or the perception of busy. I try to always remind myself and ground myself with that, to say I have to find time in silence or time in a space to be able to think. And I think that's just very important.
That's incredible wisdom there, buddy. Just out of Louisiana, or where y'all from?
So I grew up in Muscle Shoals, Alabama, not far from the Tennessee River. And my dad worked for Tennessee Valley Authority for years, but that's where I grew up. And as they say, Muscle Shoals has the swampers.
That's what Leonard Skinner said in Sweet Home Alabama.
Yes, absolutely. That's it.
Your point is incredibly well taken, because a lot of folks just look for, and I am probably guilty as being one of them, look for immediate gratification, immediate involvement. And I think often ignored is the chance to not just watch your mentors and watch your role models do things right, but additionally do things wrong. I've told my sons in their development as leaders and in their professions to not just watch folks and say, okay, I'm going to do exactly what he or she does because they are great leaders, but there are plenty of bad leaders to learn from as well. By being quiet, modeling, and watching, you can learn a lot.
No, absolutely. There are different approaches, right? And I'm by nature, I'm an extrovert. Everyone knows I'm a people person. I don't necessarily have to have a crowd. I don't have to have 20 people around me. And that's okay for those who do. But I also am completely comfortable walking through a convention center by myself, be able to say hello to everyone. So I think that's important. And the other thing about leadership, Doug, several mentors used to tell me that leadership can be a lonely place, right?
Right.
Because you're a chair. And so recognizing it, but it's not something that you should run from. Recognizing that you have to be able to find some peace with yourself in the mirror. That's number one, with your family, your faith, and those who are willing to pour into you. And sometimes just watching them do their dance and how they lead is actually an enjoyable thing. And I think that's often why we call mentors, right? You want to know, what would they do with that situation? What does this make you think of? As we say, the buzzwords from business school, right? How does that resonate with you? And you're really actually trying to pull out of them, hey, what would you do with this scenario? Or how does this sound to you? And so I enjoy that. I think the more we are willing to do that, it shows a level of humility. I try to take the approach of a servant leader. I'm not fully there yet because my career is not done, but my goal is, how can we make the place a little bit better? And better just maybe a little bit different. Doesn't mean it's right or wrong, just a little bit different for that individual, for that circumstance, or for that environment. And that hasn't steered me too far wrong yet.
Yeah, I can hear your faith and your character screaming out in those statements there. Does your dad still live down in Muscle Shoals?
Yes, he's
Okay.
still there with his several of his brothers and siblings. He'll be coming to visit me in a couple of weeks, see his granddaughters and my wife. So it'll be good.
All right, my friend, we're going to talk about this is the changes in the future in orthopedic surgery. And we've been talking through a lot of the private practice models, solo practice, medium-sized practice, large practice, mega groups. Hospital employment's a whole different issue. And UPMC, many folks may not know, y'all are a hybrid mix between the academic side and hospital employed orthopedic surgeons that are not necessarily academic, but do work for the system. Tell us about it, please.
It's one of the things that I believe is unique about our environment. It is a unique model, and it's a model that's constantly evolving. And we have our UPMC orthopedic care service line umbrella, and the core facility of that is University of Pittsburgh Medical Center in Pittsburgh. And then we have our, for years, and we still do, we have our University of Pittsburgh physicians, which are traditionally the academic University School of Medicine affiliated arm. And then we have our, what we call CMI, which is the Community Medicine Institute, which is a mix. It's not just orthopedic surgeons, but it is a multi-specialty community-based group. And that's really what helped build UPMC, both of those entities. If you go far back, prior AOA leaders as well, if you go as far back as Dr. Fu, Dr. Herndon, even Dr. Hanley when he was here, they were all private practice docs. And then that group spun into University of Pittsburgh physicians, and the community arm was established at the community hospitals outside of Presbyterian Hospital. Presbyterian was the core academic facility, Presbyterian Montefiore. But as that's grown, when I came here back in 2013, people have been talking about service lines and other industries for a while. And UPP, the academic core, and then CMI worked well together. Most of them, as you can imagine, Doug, were alumni of the Pitt Ortho program, either the residency or the fellowship, or grew up in Pittsburgh, came back to the region. And that's how the environment grew. From the standpoint of delivering top-notch, best clinical care, you had it on both sides. And the community group through our medical school, they have affiliate who are teaching or involved in our fellowships. Over time, they also have teaching appointments, essentially volunteer teaching appointments with the medical school. That's a model that other institutions have used, and we embrace it. When I arrived here, I remember, Doc, it was a trying time. You had a lot of community groups growing through acquisition, right? The health system was buying, working to become bigger. And how do you balance that with the academic? And that has continued to grow. I know we're going to talk about it more. One thing about our environment that I really like, which is why this was a chair and service line leadership role that I really was very interested in, is that we have the academic employed, community employed, but we also have private practice physicians who work out of a number of our hospitals who we also partner with. And that they are also considered a part of the orthopedic service line. And we do our best to partner with them. And I always say, if the community employer and the private orthopedic surgeon believes that Mac Hogan as the academic chair, that hat, is their biggest problem, then we've already lost our most important battles, right? How can we actually meet people where they are? It's okay for us to have disagreements in approach, but it's still about how do we provide the best orthopedic surgery care to the community. And that's an exciting thing. So in Southwest PA, we are 70-30 employed, 70% employed, 30% are for private practice groups in our hospitals here. As we move toward the center of the state, flips. We are about 20-30% of employed physicians, and the remaining 60-70% are private practice docs with different affiliation or partnership or management agreements that we may have with them.
That is incredibly complicated.
Very.
How do you keep all that organized in your head, on your laptop, wherever? How do you keep all that straight? Because you've got multiple different models going on at the same time.
Yeah, it's a team effort. One thing when I came to Pitt, Dr. Freddie said to me, he said, Mac, the service line was really in its infancy of conversation. There were a lot of groups going back and forth between health systems. That was really on the heels of some of the ACA activity and groups trying to figure out where they were going to settle. Are they going to affiliate with a health system? I think we were hitting another wave of that personally, because you just see some of the activity and a lot of activity around affiliation agreements, whether it's employed or affiliated. But anyway, Fu just said to me, he said, hey, you are politically and emotionally neutral to this place. And he said that could be good for you. And I didn't make any assumptions. I used research as my bridge because I actually really was interested in patient reported outcomes and collecting them across the private, employed, and the academic. And that's it. I reached out to a bunch of private foot and ankle surgeons. We're private. The other 5 were employed, and 4 of them were in the employed community group. I said, hey, could we collect outcomes together and
Right.
actually do some research together? We were already teaching our clinical fellowship together. So there was already a linkage with the trainees. And that's how I got really involved in service line work. And then that just kind of spawned and grew from there.
That is incredible. So if folks don't know, I'm in Bethlehem, and you can almost hit the New Jersey border with a rock from my office. It's maybe Bethlehem is a little bit there, but from our Easton office, you can pretty much look into New Jersey. And we actually have a couple of sites in New Jersey, and y'all are as far away and still within the state as possible. Y'all cover at least 2/3 of the state, if not more.
Yes, that has grown considerably since I've been here. When I arrived here, I believe we were at 24, 25 hospitals. We are now at 40 plus, in addition to our international arm.
Yeah.
And one of the hospitals in Ireland is actually an orthopedic hospital, the sports surgery clinic. And that continues to grow. One of the things that's interesting about that is when I went on my AOA traveling fellowship, North America, the plug for the fellowship, it's a great fellowship. It was West Coast. I joke, that was around 2017, 18, I believe. When I left, we had about 24, 25 hospitals. By the time I got home 4 weeks later, we had 30. you know, and I always joke about that, but it's in the 30, we had a partner with Pinnacle Health System, another AOA leader on that traveling fellowship. It was a big deal. We saw a number of people, and we were out on the West Coast, and they said, how is this managed? And I said, I'm not sure, but I think we just acquired another health system in central Pennsylvania. And that system had a residency, had a DO residency, which is very good in Harrisburg. And Ted Parsons and I were at the Miller Review teaching together, and he was the chair of the RRC. And Ted said, UPMC, you guys just acquired this DO program, and they were integrating with the allopathic pathway. And that was actually my first quadre into knowing who that residency was. And Freddie at the time, he and I were called by system leadership saying, hey, they have an orthopedic residency. We would like you, and they have orthopedic groups in Harrisburg. We want you to actually meet these guys and talk to them and talk to their practices and understand how they vibe, what are they looking for. And we took that charge on. I always try to take the approach, and Freddie was a big driver of that. You go meet people where they are, try to get an understanding of them, have them understand who you are. And so I got in the car and I drove to Harrisburg.
Okay.
And same thing, we had Hammond as a part of our group too. So we also have 3 training programs in a lot of hospitals. And I think it's going to continue to grow, Doug, quite frankly. As we said before the podcast started, I don't know a health system out there that is trying to contract, right? Becker's always puts out the list every other month. You see it, health systems that are growing. They never actually, no one ever wants to make the health systems that are shrinking list.
That would be a lonely place to be. What percentage of your FTE is clinical?
For me now, about 35%. So 35 to 40. I do 1 day of clinic and then 1 day of OR a week, and that can flux from time to time.
Yeah, if you're working 100 hours a week, that would work. Okay.
Yes, exactly. That is the gift and challenge of our fields, right? We've talked about it. And I had another mentor who's a vascular surgeon. His name was Marshall Webster. He was one of the first presidents of UPP after Herndon. And he's a vascular surgeon, and Marshall has retired now. And he said to me and several other physicians, he said, as surgeons, the administrative side of the challenging side because of the revenue that we can generate for the health system and ourselves doing what we do. And most surgeons, a lot of surgeons, particularly orthopedic surgeons, we love what we do. So, and I'm still young. I'm 45. I don't plan to stop operating anytime soon. And you can't run with bulls if you are unwilling to get dirty. So that's how I look at
That sounds like an Alabama saying if I ever heard one.
it.
All right. So the future. Let's look as far off as you're comfortable doing. Let's push you on the edge of that 15, 20 years. How long did you get your MBA?
I got my MBA in 2018.
Good deal.
Yep. 2018. Yes, sir.
There you go. Put your MBA hat on. You're looking out into the future. Where is the country look like? And the reason I asked you when you got your MBA, because you got it in the midst of a lot of the healthcare reform stuff, and I'm sure you did extensively while you were getting your degree. So you're well versed on this. So as we look out 15, 20 years or whatever down the road, what does the environment look like in terms of the very large, like UPMC, obviously highly integrated, highly diversely variable based on the different programs?
Yeah, no.
How does that look? What does it look like?
No, I appreciate that question. No crystal ball. Systems are going to continue to grow. And I do believe that you will have a collaborator parish type model. And I think that's consistent across a lot of industries, right? If we think about med device industry, that yes, there are small companies. There are some small companies that want to live independently forever, but majority of them would love to either grow to a point of favorable acquisition or grow to a point of wanting to be acquired, right? So
Right.
everybody wants to be beautiful. Whether they want to sell or not is up to them. And I think health systems are going to have a similar model. For the small health systems that are successful, they will continue to function well and want to continue to be efficient. But they are doing that. First priority should be to take care of their community and to provide care there. But the other piece is, okay, how do they drive being favorable to patients, favorable for payers, favorable for sustainability, right? So if you don't have patients and you also don't have payers who are willing to send patients to you based on your quality and based on your costs, your provider and physician network, if you don't have that, you will not, unfortunately, you may survive a little bit here and there, but you will never thrive in healthcare in the way the environment and the way it is delivered here in our country. I think that's just what it is. I'll tell you what I'm hopeful for. I told you, I grew up in Muscle Shoals, Alabama. My dad was able to have majority of his healthcare in our local area, in the same hospital that the orthopedic surgeon who fixed my ankle operates, because now they're good on their own, but they also have an affiliation agreement with University of Alabama, Birmingham, right? So for certain specialty care, even though Birmingham is an hour and 30 minutes away, they are able to provide an extension of care in that community. But a lot of that is driven, that community still has a good economy outside of healthcare. The other thing I think is going to happen is the big will get bigger, and there will be any contraction that occurs. I believe will be contraction to a then grow. So I use the analogy from a Marvel movie, but I'm a big Tony Stark guy, right? And it's one of his Iron Man movies. He takes this energy ion from his dad. He said his dad tells him in a video, I do not have the technology in my time to figure out how to make this work, but hopefully in your time you will. And he essentially contracts this energy probe and then he expands it around him, right? And that's how he basically energized the future Iron Man suits. I think that's going to happen in healthcare. Anyone who's contracting, they are essentially doing it so they have the ability to expand differently elsewhere.
Right.
It's never a desire just to contract. And I think orthopedic groups are playing the same thing, right? Think about what we do. If you contract or you shed partners, it's usually not because you want to get smaller. you actually want to move on from something that may not have been the best relationship or most efficient or most successful, and make room for something that could help the group grow in a positive way. And I think that's no different whether you're private or employed.
That's very well said. So when you're talking about horizontal integration, horizontal expansion, I've been very impressed of how y'all have multiple models within the scheme, where you can have, to your point, the academic model, the hospital employee model, the private practice affiliations. That enables you to be extremely nimble and to adjust as you move across. I mean, Pennsylvania is a very diverse place as you move across the state. It's
Yes.
depending where you go, and the needs are different. I was just in Reading earlier today, and it is much different than it is over here in our neck of the woods. So, can you talk a little bit about horizontal integration? How do you see the
Yeah.
successful large hospital practice doing? We'll get to vertical in a minute,
Mhm.
in terms of horizontal integration on that.
Yeah. So I think you have to be willing to be a little bit dynamic. And it does tie into Darwinism somewhat. Your ability to adapt and a willingness to dig deeper to understand the respective environments, regardless of whatever education I may have or whatever blessings I think I have from the good Lord I pray to, there is no way I should believe that I understand fully the culture of healthcare delivery in Ireland. I've got to trust my orthopedic surgeons who have built it there, who have built their practices there, and UPMC has happened to partner with them. You have to have a willingness of trust and, quite frankly, humility, and say, okay, help me understand how things work here. And you need a team for that. I think it is important to create a team of individuals around you who are willing to think differently. The business operational people were calling rigidity. This person's too rigid. They're unwilling to think differently. I think and to some degree, there's some truth to that, but you also have to be willing to be realistic and be, as a surgeon, as a care provider, say, hey, look, I'm delivering healthcare. We are delivering orthopedic surgery. And based on the perspective of what I have, plus my team of executive leaders and senior leaders, and insightful leaders, even if they're not the most senior, this is what we believe would actually drive success. I
Right.
think that's where we as physicians and we as orthopedic surgery leaders can really help health systems, because they are looking for success in orthopedic surgery. Make no qualms about it. The Ford Health, they want orthopedic surgery to be successful, and we want to be successful. So you have to be willing with that horizontal integration to have those conversations, say, okay, what's the landscape? Do we need to recruit? Do we actually need to shed in certain places? Where do we need to focus our attentions and get some feedback from the local community? But I'll give you a good example. And you said it. In Southwest PA, we have essentially two health plans, UPMC health plan and Highmark Blue Cross Blue Shield, for a number of years, decades. That has evolved somewhat post ACA. We have some nationals who are in play. But in central PA, a lot of people don't know, Doug, that Pennsylvania is one of the few states that has two Blue Cross Blue Shield plans.
I don't.
Highmark Blue Cross Blue Shield and Capital. You probably get a mix of both. Most states don't even have that. So why would I actually believe that in Southwest Pennsylvania, everything needs to be exactly the same everywhere else as it is in Pittsburgh? So you have to have a willingness and, again, flexibility to be dynamic and understanding that, so that you can help and drive the best decisions. And I think that's where there is opportunity in these roles as chairs, service line leaders, to actually drive and grow programs if you have a willingness to dig a little deeper and move outside of our historical comfort zone as chairs and surgeon leaders. My job is not to run my practice and lead my practice alone. It's actually to help the system be successful across all the orthopedic environment and embrace that.
I was a little negligent, assuming that everybody understood the difference. So, can you, in your own words, because we're fixing to get to vertical integration, can you describe in your words what you believe horizontal integration and vertical integration means?
Horizontal integration, how do you actually integrate, whether it be physicians, the hospitals, across that specialty area? It's different. You're right. It's different perspective on this versus when you're thinking about vertical integration. How can you essentially have every level trying from top down, trying to drive how you are delivering care? Vertical integrate consolidation, one of those, it's kind of almost an ugly consolidation, and standardization, I guess, is a better one, of how do you standardize across from the ground floor to the top floor. Everybody understands exactly how everything is being delivered. I think the horizontal integration piece is where the service lines really can you cannot go vertical if your horizontal foundation is not stable.
Exactly.
My approach has been, how can we as a service line come together more? How can we understand one another more? How can I expose to the community the challenges that the academic core that's training residents and trying to do research and trying to deliver clinical practice, how can they relate with those in the community who are also doing the same thing, but are doing it with also different pressures, and have them respect that and say, okay, great, let's stabilize our foundation together so that we can now grow vertically together and everybody win. That's easier said than done.
Very well said. And vertical integration, you talked a little bit about it, would be incorporating insurance plans,
Mhm.
X, post-acute stuff, all those things just outside the initial acute episode of orthopedic surgery. What are the payers with this? Where do the patients
Mhm.
go afterwards? How are y'all becoming more vertically integrated, and what do you see that going in the future?
I see it growing. Well, I see it expanding. So UPMC, we have a health plan, and that health plan has over 4.2 plus million lives now within Pennsylvania. And we have essentially all lines of business. We have Medicaid, commercial, and Medicare Advantage business lines of business within the health plan. And the vertical integration conversation within that is key. As we describe it, it's our integrated finance delivery system. And we are constantly trying and working to refine that. There are some areas we've been very successful, others that we're working on. And then even when it happens, Doug, how do you facilitate sustained success?
Right.
So when the CJR model came in from CMS, this is really when my service line work really expanded. When that came in 2015, since I wasn't a joint surgeon, and everybody knows I'm not trying to steal their hip and knee replacements from them, I was asked to work on that project. As you know, we talked about it in meetings, and just go out to the practices, employed, academic, community, even the private practices that worked out of our hospitals, because UPMC was on the hook, not just the physicians, but UPMC, the hospitals, and talk to them and say, what do we need to actually do to be successful? And our health plan, when you talk about vertical integration, our health plan made a decision to essentially partner with us on the hospital delivery side to have a similar bundle type quality program, which health plans can do by choice. So we essentially had our own BPCI, for lack of a better
Right.
comparative. And it was largely successful. And so from 2015 to about 2022, a year or two after the pandemic, we were largely successful in navigating costs, post-acute care costs, essentially led to, we saved money, we made additional revenue for the health system. It also served as the foundation for our Center of Excellence program for our hospitals, our Center of Excellence designation for our surgeons, which aligns very closely and very well with even the Total Joint Commission programs. And even with that, the next question is, how can we be better? How do you scale that? So what I'm hoping to do is actually then take that to shoulder replacement. Then maybe we take it to a spine program. And so now you have a vertically integrated, quality based and cost management program that puts patients with the best doctors, best locations, best care delivery. That usually leads to the best outcome. It should. And then you're going in a positive direction. Again, like I said earlier, a lot of these things are easier said than done, but we made some positive strides. We now have a platinum care program through our health plan that's based on the foundations of those things. And it was built by surgeons. Well, surgeons are the ones who help drive this. Yes, it came from a mandate from the government, but in these health systems, we have to be willing to take on the internal mandate. If everything requires the government to come in and say, we're going to do this regardless, that's a problem. The last thing I'll say on that is, the one thing about quality and cost management, it's like an MBA exercise, right? It survives every bipartisan discussion. Right? We got quality,
You got something we can agree to.
and we got something to agree to. We got to maximize quality, and we have to do it in a cost efficient manner. The blue and red blend very quickly when that conversation
Very
gets to the
well.
table.
That's true. Just to define, you said CJR, that's comprehensive joint replacement. That was the mandatory bundle, along with BPCI or bundle payment for care improvement. And now we're getting into this team bundle. How y'all being
Yeah.
y'all being involved in that, or how's that work?
Yeah, so we have a number of facilities that are involved. A
Yeah.
few of our facilities are excluded because they are either rural referral centers under the CMS designation, or they have opted out, not knowing what the team's model will look like long term. But we have several mandatories. So our Hammond region, so we will at the end of the day have about 8 hospitals across varying regions that will be active in teams and different versions of teams, whether it is the GI bowel surgery component, but spine, joints, and the hip fracture, lower extremity bundle. We have several hospitals in Central PA there, and also Northwestern and Northwest Central that are in that program. And coincidentally, I don't know if I've been voluntold or volunteered to be one of the physician executive leads for that. And a lot of that's based on what we did with CJR, right? We're the only group, if you think about it, Doug, we have a responsibility. We're one of the only groups that's ever had a mandatory bundle that continued, right? I look at that to say orthopedic surgeons are uniquely qualified to lead some of these multidisciplinary charges within health systems. And I think that as we talk about large health systems, that's something we should really be thinking about because we have that unique experience.
So lastly, Mac, let me ask you about the consolidation. How does consolidation work to improve quality, decrease cost within UPMC and as you guys move in the future, which is what healthcare is all about, right?
Yeah. Some of the main things that I've appreciated during some of these growth phases when we bring in health systems and merge, you definitely get economies of scales around certain contracting, right? And it does go both ways. Having been involved now in a few of the mergers or partnerships, and you actually then you open the books to one another and say, hey, what is your contracting with this company? And then you say, hey, what is your contracting? And you say, oh, we thought because we were big, it's always easy for Costco to assume they get better pricing than Aldi.
Right.
But you don't know until you look at it. And in theory, they should definitely get better pricing on supplies or easier to standardize certain things and actually open up some capital, right? And I think that's where opportunities do arise. So if you look at both books and you say, hey, we can help you with some of your contracting here, and now you can reallocate and reinvest those funds or savings that you have into building a better community orthopedic outpatient program, or maybe now you can invest in this additional technology that based on data analytics, either our health plan data or nationally available data that you can acquire or pay for, that your community actually needs this. They're going elsewhere. Now we can use those savings to invest in you building that program at your local hospital. And I think that is where it's great opportunity. But you have to be willing to look for those elements. And a lot of that goes to the due diligence space. In the short term, Doug, I think we all have seen what policy and governmental policy is driving right now. I think you are going to see more mergers and acquisitions and minimum through the current leadership of what's coming out of Washington, period. I think you're going to see more merger and acquisition evaluations happening. They may not all go through, but there's always been surgeons that would buckle up. You're going to see a lot of hospital systems get bigger over the next 3 to 4 years. That's just
Right.
that's my assumption.
Yeah, we could go for probably another hour talking about what was the intent of CMS and the executive branch. Did they tend to drive all this consolidation? Did anybody see this coming? Because it's certainly
Yeah.
the case.
Yeah. Well, I told you my dad worked for the government, and he said to me one time, he said, hey, he worked in energy. He said, some people are into hydropower, some people love nuclear, others are into coal. The key is keep the power moving across the lines. And for orthopedic surgery, one of our main objectives is right, have the lights burn bright, take care of people. I love telling my residents, this truly is a patient care enterprise, right? And so I love my job because I do see it here at UPMC, and I'm sure you probably feel the same way where you are. I have the opportunity to partner and lead a academic clinical orthopedic enterprise and may not always have that opportunity. And so it's actually fun. It's invigorating. Is it challenging? Absolutely. Are there some things that annoy me and keep me up at night? No question. But I wouldn't trade it. And a lot of that is because of what we do, right? We are in the best field in medicine. And I advise my residents take advantage of it now. One policy change, one event, it can flip. But our passion for the specialty should not change. And our passion to all be leaders in our own way, in the right way, shouldn't change regardless of the political or the financial environment of the time.
Tell you what, buddy, I have absolutely no question that we asked the right person to address this portion of the podcast series. And UPMC is in phenomenal hands with you out there, my friend. So glad that we're in the same state working alongside each other. This is great. So it's been my distinct pleasure and honor to talk about the changes in orthopedic surgery, specifically with the large healthcare system with Dr. MaCalus Hogan, who is chair out at UPMC. Dr. Hogan, sir, thank you once again for being on the podcast.
No, thanks for having me.
Y'all look forward to joining us again on this Futures in Orthopedic Surgery on this AOA podcast channel.